idea of the rubber dam dawned upon my mind, I was practicing in New York. It was the result of much persecution from the inroads of saliva. I had spent many an hour weary and distracted battling against its incursions. Many a sleepless night had I over sad failures, with the one absorbing question ever before me unanswered. How shall I keep the cavities dry? A case presented itself of a cavity in a lower molar standing alone on the left side, in a mouth as wet, well, as wet as water gushing from every duct could make it. In a sort of half-desperate way, and partly to try the new idea, I cut a hole in my napkin protector, and over the tooth it went. There was the rubber dam.
Dr. Sanford Barnum introduced the rubber dam to the dental profession in New York on the 15th of March, 1864. Since that time, equipment and techniques for placing the rubber dam have advanced considerably. The aims of this video are to create an awareness that there is large scope for using rubber dam in modern-day dental practice, to consider the uses and advantages of the rubber dam, to consider equipment and techniques which facilitate its application, and to show how the rubber dam may be used for routine situations in the mouth. It is advantageous to use the rubber dam for most cavity preparations and restorations. With the rubber dam in place, there is complete control over the cheeks, lips, tongue and gingiva, thereby enhancing visibility and access, especially when working at the back of the mouth or near the gingival tissue. We'll now look at the situation when the rubber dam is not being used. This patient is to have an amalgam restoration in one of the lower molars. We can see that the only moisture control, of course, is through the aspirator there. We seem to have caught the tongue with the aspirator, and the tongue is rather trying to lie over the tooth. Of course, little bits of amalgam that flick out like that might go down the oropharynx. I see one landed on the lip. Oh, whoops. Patients don't like that very much. I suppose that's happened to all of us from time to time. Amalgam debris like this is not very nice stuff to have in the floor of the mouth. And I see the tongue is interfering with the dentist there. The blood that's associated with that tooth can be seen very clearly, and of course this will tend to occlude vision when it comes to carving interproximally and so on.
Before you begin to use rubber dam, it's obviously essential to ensure that you've got the correct equipment. So let's look at some of the things that you'll need. Perhaps one of the most important things is the rubber dam itself. It's obviously best to have this in a heavy gauge because then it's less likely to tear. It usually comes in a variety of colours, but the two most commonly used are a green rubber dam and the dark grey rubber dam, because these give a very good contrast against which you can work. The sheets themselves are normally cut into 6-inch squares, which are convenient size for use in the mouth, but obviously if you're dealing with children, then there's a 5-inch square, which is specifically made for that purpose. A stamp of average tooth positions is very useful for locating the tooth centres on the dam. You can see on this stamp that we have got the arches outlined, both the permanent teeth and the deciduous ones. This helps to ensure that you can get the teeth adequately spaced, and therefore you have the correct amount of dam in between the teeth. To create the holes in the dam, you'll need to use a rubber dam punch. And for this, it's probably best to use a fixed table punch, because if there is no movement in the table, then you can cut a much cleaner hole very much more precisely. These punches therefore come in two sizes. The larger hole is the one that you would use for most situations, and the small hole where you have a small incisor teeth which may be more closely packed together. To secure the rubber dam to the teeth, you'll need to use one of a range of rubber dam clamps. The rubber dam clamp itself is carried to the tooth using a pair of rubber dam clamp forceps. These are designed so that they can widen the gap between the jaws of the clamp so that it can be stretched over the tooth. And so that it can be held in that position for carriage to the mouth, then there is this locking device which enables you to do that. It's very important with these that the jaws themselves are correctly shaped so that they do retain the clamp and so that they give you an avoidance of tilted teeth or teeth which are in a bad position. Once the clamp has been placed on the tooth, then the dam is carried to the mouth, it is passed around that clamp and between the interproximal areas of all the teeth which are going to be involved in this rubber dam placement. Sometimes getting the rubber dam through the contacts can be a little bit difficult, and therefore before doing this it's probably best to lubricate the dam using something like a brushless shaving cream. Being water soluble, it will wash away from the field of the operation without leaving any contamination. A frame will be required to pull the rubber dam out of the way of the field of operation. These frames are of two sorts, either a metal frame or they can be plastic. The plastic frame is quite useful when you're taking radiographs because it is radiolucent. When the rubber dam is tensioned on the frame, then this also helps to keep the soft tissues out of the way, but that can give an additional problem because the friction of the dam against, for example, the corners of the mouth can eventually cause a sore area there. So before the dam is actually placed, it's obviously useful to use something like Vaseline to put around the corners of the mouth. Additionally, you can use a soft absorbent napkin. It obviously adds to the patient's comfort and it's very useful for mopping up saliva around about the corner of the mouth and for wiping away the Vaseline when the rubber dam is removed. Dental tape, which is a modified form of dental floss, is used to ease the rubber dam in between the tooth contacts and to feel the contacts of the teeth prior to placing the rubber dam, just to make sure that there aren't any snags or to feel how tight or loose the contacts might be. When the dam is finally in position, then we can place the wooden wedges. These have two functions: to keep the soft tissues out of the way of the contact area and to prevent the rubber dam from being damaged by any instrumentation. And these long wooden wedges are particularly useful because they can be manipulated with the correct degree of force to place them properly in between the teeth. You may also find that you need to use some scissors, and it's better if these are blunt nosed so that there's no damage to the patient's soft tissues. And you may require to have some mosquito forceps. They can sometimes aid also in the placement of the wooden wedge, but are very useful for removing the wedges when the operative procedure is finished. And last, but of course not least, is the dental surgery assistant. She is essential in the preparation of the patient, in providing an extra pair of hands that speed up all the operative procedures, and in helping to ease the rubber dam between very difficult contacts.
Frequently, rubber dam application is made easier if more teeth are exposed through the rubber than those actually to be operated upon. The teeth at either end of the field may be referred to as the anchor teeth, and it is the choice of these anchor teeth that mainly determines precisely which teeth are to be exposed. The two most important methods of anchoring a rubber dam are with a rubber dam clamp and with a suitable contact point. A rubber dam clamp is usually necessary for holding the rubber dam to a molar, while at the front of the mouth it is usually appropriate to use the contact point between two teeth to pinch the rubber, forming the edge of the terminal hole in the rubber. Let us consider operating on a first molar. Ideally, the posterior anchor tooth is at least one tooth further back, while the most suitable anterior anchor tooth is one with medium contact pressure and smooth enamel or restoration surfaces, so that the rubber dam in this illustration includes 7 teeth. Well-formed incisal embrasures are a help in guiding the rubber dam between the teeth, whereas sharp teeth, which have been worn flat and have their contact points at the incisal edges, are to be avoided if possible. The contact between the central incisors will often be chosen. Where it is reasonable to do so, spaced teeth should be avoided as anterior anchor contacts. When operating upon anterior teeth only, the contacts between the premolars on both sides will usually serve as suitable anchor teeth, clamps not being required at all. It is essential that any adjacent contact points are exposed through the rubber dam where a restoration is to be made against them. Here, an MOD cavity is to be prepared in this tooth. It is therefore necessary, as a minimum, to have the mesial contact of the tooth behind and the distal contact of the tooth in front exposed through the rubber dam. Isolation of just a single tooth may well be satisfactory when the restorative procedure involves just the occlusal surface. Before finalizing the precise teeth to be isolated, it is desirable to pass a piece of floss or tape between the contacts so as to identify any that are particularly slack and any that are particularly difficult. Where the contacts are slack, lubricant will not be used, and where they are difficult, it may be possible to avoid them. Sometimes it will be appropriate to remove part of a restoration in order to facilitate the rubber dam application. A rubber dam clamp has a pair of jaws connected together by one or two sprung bows. The jaws, which grip the tooth buccally and lingually, may be curved or flat in terms of their relationship to the gingival tissue. Where they are curved, the clamp is particularly retentive and therefore suitable for use on partially erupted teeth, but local anesthesia will be required. A flat-jawed clamp, which is more satisfactory for gingival retraction, though fine here as shown, may be less stable on a tooth that is not well erupted. Whereas some clamps have wings, wingless clamps are usually easier to use as they allow much better access for using dental tape and for placing and wedging matrix bands, etc. Now let's look at the positioning of the holes in the sheet of rubber. There are two considerations. Firstly, the gross positioning of the group of holes so that the rubber will lie correctly related to the patient's face. And secondly, the relationship of one hole to another.
Right, let's look first at the individual tooth positions, because obviously they're determined by where the actual teeth themselves are in the mouth. The simple way of recording this is to take a blank piece of dam, place it in the correct position on the patient's mouth, and then using a pen to mark the tooth centers, just do that, like that. I won't go too far back in the arch, just enough to let you see exactly where those centers will lie. Obviously, it's very much more simple and convenient to use a stamp of average tooth position, and you'll see this mapped out on this bit of dam that I've got here. However, sometimes you may have a tooth which is awkwardly placed. It may be outside the arch, or you've got a very deep cervical cavity. So that you don't actually stretch the dam awkwardly into that position, in these circumstances it's best to place the hole actually outside the arch. In this way, this enables you to cover the displacement or the extreme area of retraction. Now that we've looked at the individual tooth positions, let's look at the position of the dam as a whole relative to the face. Normally, if you're working on the upper anterior segment in the mouth, then the holes for the incisor teeth should be placed centrally. They should be about an inch below the top edge of the dam. This allows you to have the dam in position without covering the nose apertures. If, however, the work tooth is a posterior one, then you have the problem of retracting the soft tissues on this side of the face and gaining access to the area in which you wish to work. If you place the stamp to the opposite side of the dam, then this enables you to get it in position on the tooth and to use this material on the dam to retract the soft tissues. Similarly, if you're working on a lower incisor position, then so that the nose isn't covered, if you displace the stamp to the upper edge of the dam, then by the time this is in position on the mouth and held firmly back, then obviously you can see that the nose apertures aren't covered. Should there be any inadvertent covering of the nose at this point, then it's simple to take a pair of blunt nose scissors and just cut away from in front of these apertures. If you find that the punching of the hole is incomplete, or if there's a tear in its periphery, then obviously the dam will tend to tear itself when it's stretched. To ensure accurate and clean punching of the dam, these fixed table punches give much greater certainty of location of the punch in the anvil. And as has already been said, 2 punch sizes should deal with every situation. Chris and I would now like to show you the placement procedures for rubber dam using this phantom head model. I'm going to place the rubber dam on the upper right quadrant, and I've already decided that the last molar tooth will be the posterior anchor point, and that the anterior anchor point will be the interspace between the two upper central incisors. The teeth have already been flossed so that I know how loose or how tight the contacts are, and I'm aware of the possibility of there being any snags there. The clamp has already been placed on the forceps in the fixed position, and you can see that Chris has already placed the floss around the bow of the clamp. This is just in case the clamp should dislodge during any of these procedures, or in case it should fragment, and then we have control over the fragments. To place the clamp onto the tooth, I just loosen the forceps themselves, carry the clamp over towards the posterior anchor tooth, place the jaws of the clamp against the palatal surface, and then slide the buccal jaw down against the buccal surface of the tooth until it clips into the gingival crevice. In doing it in this way, this means that I've got control over the clamp in all its movements, and also that the gingival tissues don't tend to be trapped. And when it's in position, then I simply have to test it just to make sure that it is secure. Chris is now going to lubricate the dam for me so that I can then place it over the clamp and around the teeth. That's fine. I'm now going to pass the floss through the actual molar hole so that it's kept out of the way. This enables me, because Chris is keeping the dam out of the way at the top end, to see exactly what I'm doing so that I can place the dam around the clamp and around that last molar tooth to get it securely in position there. I can then come fairly quickly forward to the anterior anchor point, and by stretching the dam so that it comes edge on into that contact area, then we negotiate that point. So the dam is now secure in the mouth. It's at this stage in the live situation that Vaseline is placed around the corner of the patient's mouth. The napkin is put on and the frame is put in position. Chris is taking the napkin, passing it over there for me. She's collected up the dam. We'll now put the frame into position and make sure that that floss is out of the way. This again becomes a four-handed procedure so that it can be done quickly and efficiently. I pulled the floss completely through the dam at this stage simply because it enables me to get a very much better seal around that tooth where the clamp has been placed. We're now in a position to put the dam properly in between the teeth because we've got very good access to the operating field. You'll find that some of the areas the rubber dam has gone through the contact reasonably adequately, and in these areas you can just pull the dam through. In other areas, it's better then to stretch the dam across the contact area so that the dam comes edge on into that space, and introduce that edge with a slight sawing motion through the contact, and this is generally called knifing of the dam. You can see that the dam hasn't quite gone through one contact here, and just so that we can show you how to negotiate a difficult contact, I'll just tease it out from that position. Chris is tensioning the dam across the tooth distal to the contact so that the edge is brought on into the interproximal space, where I can pick it up with the dental tape, and by gently passing that through the contact, then we get the dam into place, the tape itself then being withdrawn laterally so that the dam isn't dislodged. Once the dam is completely placed over all the teeth, then the margins have to be everted so as to give a better seal. There are three methods of everting the dam. The first is that while Chris is blowing air into the gingival crevice, it is simply flicked upwards so that it then comes, hopefully, to lie just against the tooth in the correct position. Should this not be successful, then with Chris still blowing the air, I can pass a blunt instrument around the gingival crevice like that to tease the dam into position. If there is a difficult contact area where we want to evert the dam interproximally, then the way of doing that is again blowing the air, passing the dam through the contact to tease it into the gingival crevice, and drawing the floss out laterally, retaining it in that position. And the last thing that we have to do is to place an interproximal wedge. The wedge has been lightly lubricated, and can be placed into the contact area with light finger pressure. This can be aided by pulling the dam slightly out of the way so that the movement of the dam into the contact carries the wedge with it, and once it's in position, then it can be broken to a more convenient length. And there you have the dam in position.
Now, we've given you a lot of information. Let's put it all together with a live clinical demonstration, and we'll put a rubber dam on an upper right quadrant.
Just open wide now.
Those contacts seem to be of about normal pressure. That's perhaps a little bit tight, that one. That one's very loose. And of course this is critical, being the anterior one. A little bit slack, but fine.
Oh, you just come around towards me a little bit.
Obviously the clamp has to be put on very gently, but one can't avoid sometimes a noise as the forceps are released. This last molar is a very long way back, so it's
Swing a little bit to the
quite a
left.
stretch to get the rubber dam over the bow of the clamp. He's just working a little rubber around the back there. Patients really appreciate the Vaseline on the corners of the mouth. And it's very helpful to have 4 hands to put the frame on. Stretch just reasonably firmly, but not too tight. Some of those remaining contacts will probably go through by just manipulating the rubber. It's where these contacts are not very tight, as we noticed between the canine and the first premolar, then a little air. That's right, you can keep blowing the air. It helps to hold the rubber dam on. So most of those contacts have gone down without any particular difficulty. It's necessary to floss between the molars, and it's easier if the dentist manipulates the actual floss, because he's got the best view. I think that's gone down all right. A lot of air is very helpful when it comes to everting the rubber, and I can see on the canine it has everted quite satisfactorily, but on the other teeth it's going to just need a little push with the blunt instrument. Chris is moving the air along as he goes. Very important ear. It looks as if the rubber might be just caught in the contact points between the 2 premolars, so that if it doesn't evert there, that would be the explanation. Now we just have to put a wedge in between the second premolar and the molar so that we can work at the mesial surface of the molar. A little lubricant always helps, and he's just broken the edge off there. So there we are, we have the rubber dam in position, and we're now ready to proceed with the operative procedure. Now, removal of the rubber dam. The important thing here is to have a quick and efficient method. Stretching on the palatal side is relatively simple for upper dam removals. And she's managed to cut all the interseptal rubbers. And that all comes off together in one movement. And then the napkin is very useful for just wiping the patient's face at this stage. Now there's one other thing, single tooth isolation, as for example when a tooth only requires an occlusal opening for endodontic treatment. So the rubber's being put on the frame here and stretched so that it's just nicely held in place, and the clamp can then be fixed via its wings through the hole in the rubber, and so that the three are all joined together. And then by picking up the clamp with the clamp forceps, then the whole combination can be taken straight to the mouth, and the clamp will just fix it all to the tooth. And very rapidly, the dentist will be in a position to proceed with his restorative procedure. And it's very easy for the patient at the same time. So he's now ready to go. A positive attitude towards the rubber dam is probably the most important factor relating to success in learning to use it. Of course, initially extra time will be taken, but it needn't be long before the rubber dam is making dentistry easier and allowing a definite increase in quality. With practice, there will also be an increase in speed, and the rubber dam will become an essential tool. Indeed, the dentist may well come to wonder how he or she ever before managed without it. The range of clamps to be described are labelled A to K in order of priority. A W appended to a clamp indicates that it is wingless.
The AW clamp has curved beaks and is the one you should use in most molar situations. It is a retentive clamp with a 4-point jaw contact. If the tooth to be clamped is on the large side, then an FW should be used. And when the anchor tooth is small in diameter, then the appropriate clamp is the GW. In situations where the clamped tooth is also the one on which the operation is to be performed, and additional access is required to its distal aspect, there is an extended bow version of the AW, which is the HW. When a molar tooth has good available natural undercuts, a BW clamp can be used. It has a linear tooth contact with a flat jaw angulation. If the molar is large, the JW may be more appropriate, whereas if it is small and the BW is unstable, then a DW should be used. The EW is universal for incisors, canines and premolars, and any of these last four clamps may be used for gingival retraction as well as for anchoring the rubber dam. However, for gingival retraction of a premolar, canine or incisor, where for example it is necessary to expose a cervical cavity, the regular double bow C clamp has been specifically designed. There are two additional versions, the C1 for deeply placed buccal cavities and the C2 for deeply placed lingual ones. But for most uses, the regular clamp will suffice. The remaining specialized use of clamps is where single tooth isolation is considered adequate. Winged clamps are designed for this situation as they allow the dam to be carried to the tooth on the clamp. The E clamp is for very small teeth, the G is a retentive form for average diameter teeth, and the K is for large molars.